Good morning, hello, and welcome to today's presentation from the Erie County Office of Health Equity. Today, we're going to be covering some information on the Office of Health Equity and our findings from our 2023 Health and Wellness Survey. First, I'd like to get started with some introductions. For those of you that don't know me, I am Kelly Marie Wolford. I'm the director of Erie County's Office of Health Equity. Mike Weiss is our lead epidemiologist who led the survey analysis and writing of our report. And Laura Inkarunji is also an epidemiologist with our office and was responsible for survey design, data analysis, and report writing. You're going to hear from both of them for most of the presentation today, but I do want to begin our time together with a series of acknowledgments that we believe are important for setting the tone of our work today. First is our land acknowledgement. The Erie County Office of Health Equity would like to begin this report by acknowledging that we, as Erie County residents, are on the land of Indigenous peoples. Traditionally, these lands were home to many nations, including the Neutral, Erie, Werno, Huron, and other peoples. Today, these lands are still regarded as the traditional homelands of the Seneca and other Haudenosaunee peoples. We respect the treaty rights of the Six Nations, the Seneca, Mohawk, Cayuga, Onondaga, Oneida, and Tuscarora, and the obligation of the United States and New York government and American society to adhere to them. We would like to honor the legacy of the many elders and ancestors who made this land their home and infused it with their spirit for thousands of years. We also honor the original peoples who remain on the ancestral homelands of Turtle Island and who have survived centuries of colonialism, genocide, and land theft. We honor those whose lives have been impacted by historical and intergenerational trauma across lifespans and generations, including land dispossession, forced relocation, and forced assimilation through boarding schools like the Thomas Indian School, which was located on the Cattaraugus Territory in Erie County. Finally, we honor those who are not here, but who might have been were it not for this history of violence. With hearts and minds focused on healing and truth, we remember the powerful example of democracy and federalism set by the Haudenosaunee, embodied by the great law of peace. Through this inspiration, we commit ourselves to advocate for inclusion and acknowledge and address past atrocities. May we all aspire to a world of reconciliation, guided by the example of the Haudenosaunee themselves, so that our weapons of war are buried forever, and mutual respect and equality prevail among all peoples and nations. Next is our enslavement and labor acknowledgement. The Erie County Office of Health Equity respectfully acknowledges our debt as a society to the people, past and present, whose labor was and continues to be stolen through unjust practices, including the exploited labor of incarcerated people. We acknowledge our debt to the enslaved people, primarily of African descent, whose labor and suffering built and grew the economy and infrastructure of a state that did not abolish the practice of slavery until July 4th, 1827. While not a Southern state, New York had the largest population of enslaved people of any Northern state, and it was second to last in abolishing the practice. Erie County, established in 1821, became an integral part of the journey to freedom for enslaved Black people via the Underground Railroad. The homes, businesses, and land of abolitionists were used to assist the enslaved making their way to Canada to live as free people. Landmarks such as Freedom Park are historical hallmarks of the Underground Railroad. The very land on which the Edward A. Rath Building is built was the former home of abolitionist and attorney George W. Johnson. Ramifications from the practice of enslavement in our country are still present today, visible in the systemic racism perpetuated in our institutions, in the segregation of our residents, the exploited labor of incarcerated people, and in the many of the inequities in the social determinants of health and health disparities experienced by their descendants. The spirit of freedom embodied by our ancestors, enslaved and free, persists as well, visible in our social justice movements, increased awareness of historical and ongoing inequities, and advocacy for change. The Erie County Office of Health Equity will embrace and embody the same spirit of freedom to help eradicate the systemic racism, poverty, and oppression plaguing so many of our Erie County communities. Our last acknowledgement is our community recognition and acknowledgement. The Erie County Office of Health Equity would like to take this time and space to recognize and acknowledge the often overlooked and forgotten work of community in the fight for equity and justice. Everyday community members, community activists, and organizations have been engaging in equity and justice work long before the term became commonplace. Most of the staff of the Erie County Office of Health Equity have their roots in community work and bring that framework to this government setting. Governments, corporations, organizations, and people in positions of power have a history of erasure, historical revision, and appropriation of the work of others as their own innovation rather than naming and uplifting and adopting community-grown solutions. We must be purposeful in acknowledging and crediting frameworks and foundations, and intentional in acknowledging the roots upon which we build and grow. Following in the steps of cultures documenting their journeys through storytelling and oral history, passed through the generations, we seek to keep the work of those that came before us alive. We are all the descendants of people that may never be named or credited for their contributions, yet the work we do is embedded in our DNA and intergenerational wealth of knowledge beyond measure. To name a few community organizations and leaders in this space would be to miss the multitude. There are so many contributors to this work, most of whom have no title or office. The progress our Erie County community has made is rooted in the efforts and accomplishments of countless individuals and community organizations. Thank you. So here is an overview of today's presentation. I encourage you to use the chat. Um, and I will be monitoring the chat, and we will have questions and answers at the end of our presentation today so that we can get through all of the data. Don't wait to put your questions in the chat. Feel free to drop them in there whenever they pop up. So we'll start with a quick background of the Office of Health Equity. Then we're going to talk about the timeline and methods of the Community Wellness Survey. We'll look at the demographics, and then we'll quickly go over the social determinants of health because we frame the results of the survey around those factors. And lastly, we'll look at some of the selected results of the survey. We'll end our time today with questions and answers. So again, please feel free to use the chat. We'll be monitoring the chat for questions, and we'll get to them all at the end of our time today. So before we get into the Community Wellness Survey results, I want to take a little time and discuss a brief history of the Office of Health Equity. Our office is a part of the Erie County Department of Health and was established by the passing of the Erie County Health Equity Act of 2021. The vision of the office is for all disadvantaged, marginalized, and diverse populations in Erie County who presently experience higher rates of poor health outcomes to achieve maximum health and wellness. The Erie County Health Equity Act of 2021 outlines the key activities and the scope of work and the type of work to be done by the office, and we're going to quickly cover those. The activities and functions outlined in the law, which is available on our website, include that we'll conduct data analysis. This is to better understand and measure health disparities in Erie County. Health disparities are preventable differences in diseases or preventable differences in opportunities to achieve good health that are experienced by socially disadvantaged populations. Health disparities is often also called health inequities. The law also instructs us to use the data and information we have to better understand the underlying factors that are creating the health disparities and then connect those factors to health outcomes. The office is also directed to make recommendations that would improve the delivery of healthcare or improve access to healthcare. Additionally, the law gives space for us to pilot programs and instructs the office to increase awareness around public health and health disparities. Lastly, the law requires that we report on all of the activities of the office on an annual basis, which leads us to the report we're going to be discussing today, our 2023 annual report for the Office of Health Equity. The full report, which is available on our website, contains multiple sections, including the acknowledgments that I just read at the beginning of our time today. After the acknowledgement section, there is a history on the Office of Health Equity, and it's followed by summaries of all of the pilot programs and the work that we did in 2023. That includes programs and activities such as mental health first aid, our holistic health program, our grants work and grant technical assistance, and our newsletters if you receive those. The largest part of that 324-page report contains the findings of our 2022-2023 Community Wellness Survey. Followed by the survey, there are several appendices with additional information, all of the flyers, the survey itself that we use, and framework and tools that you can use in your work. During the rest of today's presentation, we're going to be focused on the findings from the survey. So again, I encourage you to use the chat to ask any questions whenever they pop up. We'll see them and get to them at the end of the presentation. But before we jump into some of the key findings of the survey, I wanted to just take a moment and provide a brief summary of the timeline for the whole project. So in February 2022, we convened a community work group to help in the survey development and with the design of the questions. Some of those folks are in the room today. The survey was written in March of 22 and was revised and edited with that group until May of 2022. Then for the rest of 2022, the surveys were distributed and responses were collected at community events throughout Erie County. From March until May of 2023, the survey data was cleaned, basic analysis was done, and around this time, we also began community group or focus groups within the community, the planning phase of the focus groups within the community. From July until September of 2023, we conducted 14 different focus groups throughout Erie County. And lastly, the analysis portion of the data and report was written at the end of 2023, the report being released at the beginning of this year, 2024, and we will have the focus group report released later this year. So during the process of reporting, of developing, of implementing, we identified some limitations in the survey process and in the collection of survey results. Limitations doesn't mean we would have done anything necessarily different, but we did identify some limitations in the work. Ideally, we would have liked to piloted the survey in the community, but because of time constraints, we didn't conduct any testing of the survey within the general public. Doing that may have identified some flaws that we found later with question design and analysis. Another lesson learned was the use of open-ended questions. So these are the type of questions where survey respondents can write any answer they want. We had about over 4,000 surveys collected, and these open-ended questions had such a wide variety of responses, it was just completely impractical to conduct data analysis on them. One of the interesting side notes was that these fields did help us detect where automatic or survey bots were used to complete the survey. Because of that, we were able to pull out about 400 responses that shouldn't have been allowed. Another one of the lessons learned was that despite the very intentional efforts of our team to reach minority and marginalized communities, we were still unable to gather a larger number of surveys within some of those groups. The small sample size limited our ability to present data about these specific groups, and Mike and Lara will discuss this a little bit more when they go into the discussion of the results. And one last limitation I'd like to discuss is that this survey was a non-representative sample of the county, which was purposeful. We intentionally focused on groups that were traditionally underrepresented in surveys, in research, in this work, or even excluded entirely. So now I'm going to turn the presentation over to Mike, who will lead us through our next step. Mike?
All right, thanks, Kelly. All right, as Kelly mentioned, I am Mike Weiss. I'm one of the epidemiologists in the Office of Health Equity, and I'm going to start off today discussing some of the basics of the survey, and then I'll talk about some of the demographics, and then we'll go into the survey responses and the results. So the 2023 Health and Wellness Survey was intended to explore challenges and barriers to health and that the individuals in Erie County are facing. The survey had 41 questions that asked about three types of questions. We had demographics, health behaviors, and then questions around the social determinants of health. The questions were mostly multiple choice, often where the respondent could select all that applied to them in that situation. An example of this type of question is shown in the bottom left of the screen. Here we asked, lack of transportation has been a barrier to, and then they could select all that apply. So for example, an individual could select that it was a problem accessing medical care and buying food and other needed goods and finding or keeping a job. All those could be selected as a response to the question. On the right, you'll see an example of our other type of question we used, which is a Likert scale question. Likert scale is really just a fancy name for the type of question where a respondent can select an option that best corresponds to how they feel about the statement. Our Likert scales were basically reflecting frequency or how often something occurs. The options that we offered were never, rarely, sometimes, often, and always. And so the example here on this slide says, do you have friends or family you can rely on for practical help, emotional support, and having fun? And for each part of the question, a respondent can pick from the Likert scale. So for an example, someone could say that they felt they had friends and family they can rely on for practical help. Sometimes they can select sometimes there. And then for emotional support, if they felt that they received that often, they could select often there. Those were the two main types of questions that we used within the survey. We're going to start our discussion of results by showing some of the demographics of the individuals that completed the survey. Before that, I want to expand on what Kelly talked about with us collecting surveys from the community. Of course, we used the internet and we posted it online and we had everyone share the link to take the survey, and we tried to get as many people to do it that way as possible. But as Kelly said, we also made it a significant effort to go out into the community and go exactly where people are within Erie County. And that was over the course of about 6 months. Our fantastic community engagement team went to fairs, festivals, events all over the city, all over the county to collect those survey responses for us. Additionally, our office partnered with the Buffalo Center for Health Equity and the Witness Project for survey collection. We have the QR code here for the website for the Witness Project if you'd like some additional information about their work. But for this survey, the Witness Project staff collected responses mostly by going door to door within the east side of Buffalo. And so on this slide, you're going to have two maps that represent where and how many surveys were collected by both the Witness Project and the Office of Health Equity. These maps show the number of surveys collected based on the zip code of the person completing the survey. You can see on the left here, that's the Witness Project, and they mostly did get those surveys from the city of Buffalo, and you can see a concentration of survey responses on that east side of Buffalo. On the right, you have the surveys collected by the OHE team. We also got a fair number of surveys from the city of Buffalo, but you can see in addition to this, surveys were also collected from people living in pretty much every zip code in Erie County. There are actually only 2 zip codes in Erie County where we were unable to collect any responses. One is zip code 14260, which is part of the University of Buffalo, and actually no one really lives there. It's just part of UB. And then the other zip code without responses was zip code 14069, which is kind of hiding down here. It's the Glenwood area near Colden, and census data says about 800 people live in that zip code. So it's a relatively low population zip code to begin with. So collecting surveys was a kind of a challenge in those low population zip codes. But as a result, we included a total of 3,451 survey responses that were included in the analysis. 1,028 of those were collected by the Witness Project, and our Office of Health Equity collected the remainder, which was 2,423. So those maps told us a bit about where people live that completed the survey, and here's some other factors, demographics about the people that completed our survey. We have here age, race, ethnicity, gender, and sexual orientation are also shown on this slide. So the bar chart over here on the left is showing our age groups of survey respondents, and you can see age of respondents was spread across really all the age groups, with the most respondents being 30 to 39. We did have the fewest number of respondents in the 80 and older age group. In the center of the slide, you can see our responses by race and ethnicity. For race, the largest group of respondents was white with 1,445. 1,389 were Black. After that, the next highest is more than one race with 111, and then Asian with 107. This survey did break out. We did ask those that selected Asian to select a country of origin, and we gave 9 additional Asian country of origin options, including India, Bangladesh, Burma, China, Philippines, Japan, Korea, Pakistan, and Vietnam. But as Kelly kind of mentioned in our limitations, despite our efforts to try to reach some of these smaller minority populations, most of these Asian subgroups had very few responses. So in many of the results and in the visualizations that we're going to show today, the Asian subgroups were actually combined back together into one single Asian group. For ethnicity, we did have 269 respondents that said they were Hispanic or Latino. That's about 8% of our responses. Like the Asian groups, we did break out Hispanic country of origin, but like Asian, the Hispanic subgroups had very few responses in general. The only one with significant number of responses was Puerto Rico. So the Hispanic group was recombined, and you'll see in the results that we generally just present it as Hispanic Latino, and we don't often present the breakout of Hispanic subgroups. And then our survey also asked about sexual orientation and gender. For gender, most respondents did identify as male or female, but other gender identities, including trans, non-binary gender, non-conforming, were all represented in the responses. And for sexual orientation, most of the respondents did identify as straight or heterosexual, but we did have a variety of responses from across the spectrum. In this slide, we're looking at a few more demographics. On the top, you can see an immigration question that we asked. Most respondents were born in the US. We did have 105 respondents born in US territories and 218 respondents born outside the United States. On the left of the slide, you can see respondents reporting their highest level of education. The most respondents were in the group that said they had a high school degree or GED, and the second largest group was those that had a bachelor's degree. And then right below that, you can see employment. We asked if you were currently employed or not. And at first glance, this looks pretty like a pretty high unemployment rate. But we asked a follow-up question for their reason for unemployment that we're not showing here. But a large percentage of those that listed that they were currently not employed were because they were either younger students or because they were retired. And then in the middle of the screen, you can see history of our incarceration. We had 306 respondents that said they did have a history of incarceration. Below that, you can see we had 618 respondents that said they had a disability. And then over to the side, we have 173 respondents that responded that had a history of military service. So in addition to the demographic questions that we asked, we had several health behavior questions. They included challenges to maintaining a healthy diet, challenges to getting enough exercise, and questions about substance use and struggling with the use of any kind of substance. And then the survey also asked about a few health outcomes. You can see here 2 questions that we asked. The first was, do you experience any of the following health conditions? And then we provided this list for respondents to select from, and they could select all that applied to them. As you can see, we do include things that are physical conditions. Most of them are like that. That's things like high blood pressure, diabetes, kidney disease. But then we also included a mental health kind of illness there with anxiety and depression as an option. And additionally, we asked respondents if they had lost a close relative or friend due to COVID-19. All right, so this brings us to our questions around the social determinants of health. And as mentioned previously, the majority of the questions in the survey, as well as the way that we overall presented the results in the report itself and in the presentation today, are going to be structured around these factors. And so on this slide, you can see a visual representation of each of the 6 domains of the social determinants of health. And I'm just going to briefly go through them and touch on some of the factors that are part of each one of the domains. So starting with economic stability in the green, this domain includes factors like poverty, housing, security, employment, and medical costs. The purple domain is our neighborhood and built environment, and that contains factors like green spaces, parks, walkability, water and air quality, grocery store locations, medical care locations, things like that. The red domain is the healthcare system. This domain is really all about access to care and the quality of that care that you receive. Up at the top in orange is the domain of language access. This is things like translation, interpretation, literacy levels, really anything that impacts the ability to communicate. Below that is the social and community context, that's in blue. This has factors like trauma, stress, stigma, racism, isolation, and social supports. And lastly, in the kind of teal color, we have education, which covers the quality and the access to education that individuals have. This is across the entire lifespan, so it's from pre-K all the way through higher education, college, and includes other things like vocational trainings and workplace development. So as we discuss the rest of the findings from our community survey, we're going to actually present each one of these domains and tell you a bit about the questions that we asked in that specific domain. And then we're going to display some of the results that we found most interesting. And just to kind of reiterate, this is really just scraping the surface of the findings that we have in the overall report. We encourage everyone to look through the entire report. There's a lot more in there, and then there's even more in the appendices that supplement our findings. So that brings us to our first SDOH domain, which is economic stability. In this survey, we asked about employment, financial situation, and the hopes that someone had for their finances. And then also on this slide, you can see a quote from one of our focus groups. At the start of each one of our 6 domains, we're going to put up a quote that kind of represents that SDOH domain. And for economic stability, we have here a quote from our rural older adult focus group. That really reflects the importance of finances and that connection to a healthy life. So I'll give everyone a chance to read that quote. All right. So at the top of this slide, you can see how we actually asked about financial situation. So instead of asking respondents for like an income range or a household income amount, we instead asked participants in the survey, which of the following best describes your financial situation? And here you can see the response options. There was, I have enough money that I'm able to save some, invest some, and buy things that I want but don't need. We shortened this to, I have more than enough money. The next option was I have just enough money to pay for housing, day-to-day needs and bills, which was shortened to just enough money. And lastly, I am unable to pay for all of my household day-to-day needs and bills, which was shortened to not enough money. The pie charts below show the percentages of respondents in each one of these categories, excluding the do not wish to say. Not enough money is in the darkest green color. Just enough money is in the middle, kind of regular green color, and then that lighter green is more than enough money. The overall percentage of each group from all respondents is this leftmost pie chart. So that's everyone that took the survey's response. You can see that moving over to the one of the middle ones here, that respondents who said that they had a history of military service were more likely to have not enough money. So that's 23% as compared to all respondents who only had 18%. Respondents with a history of incarceration had an even higher percentage. You can see they had 38% of the time reported not enough money as compared to that 18%. And then in a similar way, anyone that said that they had a disability, 32% said they had not enough money as compared to 18% of our overall respondents. Additionally, we have a map here of the percentage of respondents in each zip code that have more than enough money. So that's the highest level, the most highest feeling about their financial situation. So the darker the green, the higher the percentage of respondents in that zip code who said they have more than enough money. So what you can really see in this map is that the suburbs around the city of Buffalo, that kind of first ring suburbs, is got the highest percentage of individuals that have the more than enough money. And when you look at the city of Buffalo and some of our most rural areas of the county, that has the lowest percentages of people that feel like they have more than enough money. I also want to just point out that we're going to show a few maps over the course of the entire presentation. And sometimes, as you can see here, we have zip codes that have no responses. So they're going to be shaded in black. Additionally, we just want to make everyone aware that some of the zip codes have small populations to begin with. So zip codes that are in some of our most rural areas of the county have low populations. And so as a result, we were only able to collect 10 or fewer responses in many of these rural zip codes. And so we just really wanted to point that out and make you aware that that is one of the limitations we had in interpreting our results. All right, and at the top of this slide, we're showing a question that asked respondents about challenges around food situation. It states which of the following best describes your food situation, and then they could select any of the responses that applied to them. Based on this question, we were able to see 22% of respondents, or more than 1 in 5, who use SNAP or WIC to buy food, also said their household is not able to get enough food. So this means the respondent actually selected, my household uses SNAP WIC to buy food, and they also selected my household is not able to get enough food. So despite people getting food assistance from programs like SNAP and WIC, they're still often not able to get enough food for themselves or their families. We then actually took this question of food situation and grouped people into 2 categories. If the respondents selected any of those responses in the bracket, they were grouped into having food access challenges. And then that's the left column of the table. If they stated they are able to buy enough food with their salary and wage money, they were placed into the group of no food access challenges on the right. These food access groups were then crossed with our question we previously talked about which of the following best describes your financial situation. And in the table, the darker the green indicates a higher percentage of responses. As you can see here, individuals, 11% of people with more than enough money have food access challenges. And you can compare that to 85% of those who said they do not have enough money have food access challenges. So this just shows how your financial situation impacts your ability to buy enough food for yourself and your family. So, and lastly, in our domain of economic stability, we'll look at some of the health conditions that respondents reported based on their financial situation. 21% of respondents stated that they had not enough money listed obesity as a health condition, compared to only 15% with more than enough money. So you can see that increase based on finances. 31% of respondents who stated that they have not enough money listed high blood pressure as a health condition. Only 20% with more than enough money listed that as a health condition. And kind of on the opposite side of things, 40% of respondents who stated they have more than enough money had none of those listed health conditions. They selected none of these. And you can compare that with only 28% that selected none of these with just enough money, and then 24% with not enough money. So almost it completely declines as you go down that financial situation scale. These findings really highlight how an improved financial situation is connected with better overall health. And on the other hand, having a challenging financial situation really makes you more likely to have some worse health outcomes. All right, so now we're going to move to the next domain, healthcare access. In this domain, we asked questions about the challenges to accessing healthcare. We asked about treatment by healthcare providers, and then those health outcome questions that we just touched on, the health outcome list, and then the COVID-19 question. Here you can also read a quote from one of our focus groups about the challenges that they experience within the health system and healthcare access. And I'll give everyone just a minute to go ahead and read that quote. Okay. So stick with me on this one because there's a lot of explanation about the question itself, but we asked respondents to answer the following series of questions. So the question was, when I receive medical care, I feel that providers respect me, I feel that providers believe me, I believe that providers speak to me in a way that I understand, and I feel that providers are competent in treating people like me. And so for each one of these bulleted questions, the respondent could select from that Likert scale that I discussed earlier. So they had the options of never, rarely, sometimes, often, and always for each one of these 4 questions about medical care. So for an example, a person could select always for I feel providers respect me, and then they could select sometimes for I feel providers believe me. So then to analyze the responses that we got from the survey, we converted the responses into a numerical value. So never became 0, rarely became 1, sometimes became 2, often is 3, and always a 4. And then for the chart that we're showing here on the right, we actually averaged the scores of all 4 questions into an overall metric we called treatment by providers. And so that the graph here shows that metric by educational attainment level. And so you can see that as individuals achieve higher levels of education, the treatment by providers increases. So an additional note that we have on this slide is that only 18% of respondents that identified as trans, non-binary, or any other gender group felt that they were always believed by providers, and that can be compared to 35 and 37% of respondents who identified as man or woman on their gender question. So this finding really highlights how factors like gender identity and education impact how a person is treated within the medical care system. Here we're showing some of the counts of responses to the question. We asked of which of the following challenges to accessing healthcare for you and your family. Respondents could select all the challenges that applied to them. The more that the responses had, the number of responses, the larger the circle here. And so you can see a wide variety of responses. And overall, the biggest challenge selected was the cost of care and treatment. The types of challenges that people reported to accessing care did vary based on their demographic factors, and we have an example here for you. The younger respondents between the ages of 20 and 40 years old were actually more likely to report conflicting schedule, lack of childcare, and lack of paid time off than our older respondents to the survey. And lastly, in healthcare access, we're going to show the results of the health conditions. So that's the question of, do you experience any of the following health conditions? As you can see in the bar chart, the most often selected response was anxiety and depression, and then that was followed by high blood pressure. Furthermore, when we looked at these when we looked at individuals who reported any of those challenges for accessing healthcare, so thinking back to the circles from the last slide, respondents that listed any of the challenges to accessing healthcare were more likely to report experiencing physical health conditions. So 77% of respondents who reported one or more challenges to accessing healthcare also reported that they experienced one or more of those listed health conditions. By comparison, only 61% of respondents who selected that accessing care was not a challenge reported one of those health conditions. All right, and now we're going to talk about the domain of education. In this domain, we asked individuals their highest level of educational attainment. And on this slide, you're also seeing a quote from one of our Hispanic and Latino focus groups that highlights some of the challenges around education. And I'll give a minute to read that one as well. All right. So the chart that I'm showing here is a breakdown of educational levels by race. The legend under the chart shows the colors that represent each educational level. So you can see that white respondents had the lowest percentage of did not finish high school with 4%. Black respondents actually had the highest percentage of high school or GED equivalency with 38%. But what's really interesting is the results when we look at this Asian race group. They had the highest percentage of postgraduate degree at 23% of any of the race groups. They also had the highest percentage of the did not finish high school group at 22%, which really highlights the diversity within the Asian race category and shows that our need to disaggregate that data is definitely there whenever we can do that. So if we do break out that Asian group into that country of origin, we see that all Asian respondents who listed their country of origin as China in the survey stated that they had at least a college degree. And then on the other hand, 69% of Asian respondents from Burma said that they did not finish high school. So that's how we get this kind of polarization of the Asian group is from those subgroups. A few additional notes about education are at the bottom of the screen. We see that 62% of respondents with a disability had no college degree, compared to only 45% without a disability. And then 82% of respondents with a history of incarceration had no college degree, compared to 46% with no history of incarceration. All right, and on this slide, we are showing the percentage of unemployed individuals based on educational level. This does exclude anyone that's younger than 18 because we are assuming that they're probably still in school. And then we also excluded respondents that indicated that they are retired. And then here you can see a very clear decrease in unemployment as educational attainment increases. So in other words, as your formal level of education goes up, your unemployment goes down. And lastly, in this section, we have challenges to eating a healthy diet broken out by educational level. So again, this was a question where individuals could select all that apply, all the challenges to eating healthy that apply to them. In the table that you're seeing, it's the higher the percentage, the darker the color of the cell that the cell is shaded. Affordability was the biggest challenge to eating a healthy diet across nearly every educational level, with the exception of postgraduate degree, where you can see actually time becomes the biggest challenge to eating a healthy diet. It's also pretty high up for individuals with a bachelor's degree as well as the biggest challenge. But for those individuals that have lower levels of educational attainment, knowledge, actually knowing what healthy foods to eat, are more likely to be the challenge that they point to for eating healthy. And then on the right, we have a finding from the challenges to exercise by educational level. So time, it was the leading challenge to getting enough exercise for those with a college degree. And then that was followed by pain or illness and gym access. But what we noticed is as levels of formal education decreased, respondents were increasingly reporting gym access as a challenge. So 20% of respondents who did not finish high school listed gym access as a challenge. And that can be compared to only 9% of respondents with a postgraduate degree saying gym access was a challenge. All right, so I am actually now going to turn over the other 3 domains to Laura, and she's going to talk about the other 3 SDOH domains.
Good morning, everyone. I'm Laura Nkurunji. As Mike said, I will be discussing the remaining 3 domains of the social determinants of health. So next, we will look at neighborhood and built environment. Our questions within this domain primarily focused on housing and transportation. In this presentation, we're going to look at some responses related to housing. This quote from one of our focus groups reflects the challenge of cost when it comes to housing. We can take a moment to read it. Okay, so first we'll look at the overall breakdown of the housing situation of our respondents. So 42% reported that they own their home, 46% reported that they rent their home, 8% reported staying with friends or family, 3% reported staying in a shelter or transitional housing, and then 35 respondents, which comes out to be about 1% of the survey respondents, reported that they do not have housing. Of those 35 respondents, 57% also reported that they have a disability. And then cross-referencing with financial situation, 53% of respondents who own their home reported that they have more than enough money to pay for day-to-day expenses, in contrast with 24% of respondents who reported that they rent their home. Okay, delving into home ownership. This image looks at home ownership by race. The vertical bars show that 64% of white respondents reported owning their home, while of anyone who selected any other race, only 23% reported that they own their home. The horizontal bars here break down that group of people of color. We also looked at home ownership by Hispanic Latino ethnicity, and we can see that people who reported their ethnicity as Hispanic or Latino were less likely to report that they own their home than respondents who reported being non-Hispanic Latino. Looking further into the differences in home ownership, we look at respondents who reported owning their home by race and education attainment. And the results show vast inequities in home ownership by race, even when controlling for education level. So, for example, white respondents with a high school diploma or GED as their highest level of formal education were more likely to report owning their home than Asian respondents with an associate's degree, and Black respondents and respondents of all other races with a bachelor's degree. And then looking at some health outcomes by housing situation. For these graphs, we grouped together respondents who reported living in a shelter or transitional housing with people who reported being unhoused. That group was the most likely to report having asthma, as well as anxiety or depression, followed by people who rent their homes and then people who own their homes. However, I will note that in some age groups, people who own their homes reported slightly more anxiety and depression than people who rent. All right, next we'll look at language access. And while this domain can be explored more broadly to include general information access, in the survey we focused on challenges related to spoken language. This quote from the Puerto Rican focus group demonstrates an example of these challenges. We can take a moment to read it. Okay, On this slide, we'll look at English proficiency broken down by some demographics. On the top left is the question and response options about English proficiency. For the bar graphs here, we grouped the categories not well and not at all, and excluded respondents who selected do not wish to stay. The graph with the vertical bars displays English speaking ability by Hispanic Latino ethnicity. We can see that Hispanic Latino group was less likely to report that they speak English very well, though the majority of them, which was 78%, did report speaking English very well. And the bar graph on the bottom displays English speaking ability by race. So this shows that Asian respondents were the least likely to report that they speak English very well. Differences were observed when both the Asian group and Hispanic Latino group were disaggregated by country of origin, but there were not many respondents within those groups when disaggregated this way. The map shows percentages of respondents from each zip code that reported speaking English very well. So the darker the orange, the higher the percentage of respondents who reported speaking English very well in the zip code. So we can see some in the rural areas in the city, there are higher rates of lower than very well. Here we cross-reference education and employment with English speaking ability. The graph on the left shows English speaking ability by education attainment. We can see that the respondents who did not finish high school were the most likely to report that they speak English less than well. The graph on the right shows that respondents who speak English less than well were less likely to be employed. And here we break down health outcomes by English speaking ability. So this is the question we saw earlier about health outcomes. For this analysis, we labeled anxiety or depression as mental illness and categorized the other conditions as physical illnesses. Now, I had assumed that respondents with lower English proficiency would report more health challenges, or more health conditions due to challenges associated with language barriers, such as not being able to access proper care or connecting with other people for support. However, as demonstrated in this graph, that was not the case. There may be several explanations for this, and it's probably a combination of factors, which may include lack of diagnoses due to lack of access to care, different views of health, particularly mental health, and it could also be healthier cultural practices in some of these groups. And moving on to the last domain, social and community context. Survey questions within this domain explored access to social supports, responsibility for young children, living with an adult who requires care, history of incarceration, and place of birth, which identifies respondents who moved to the U.S. from another country or territory. For this presentation, we're going to focus on social support. And this quote from one of our participants in the rural adult focus group highlights the importance of having social connections. I'll take a moment to read it. Okay, so to explore social support, we asked survey respondents how often they could rely on friends or family for 3 separate types of social support. Those are emotional support, having fun, and practical help. So help with things like childcare, transportation, minor home repairs, things like that. We use the same Likert scale that we use in rating healthcare experiences. We had respondents rate the frequency of each type of support, starting with never, which we assigned the value of 0 to always, which we assigned the value of 4. Greater differences in levels of support were observed across life experiences than across basic demographics, and we'll look at some of those experiences. On this slide, we compare how participants rated their levels of social support between those who selected that they experienced challenges to accessing transportation with those who selected accessing transportation is not a challenge for me. So you can see how we grouped some of those responses together. On the y-axis or vertical axis, is a scale of these support values as an average. We can see that respondents who indicated that they have transportation challenges rated their levels of support lower than those who indicated that they do not have challenges accessing transportation. So based on the way that the question and responses are worded, this doesn't measure so much the amount of support an individual receives, but more the adequacy of support. So for example, there could be someone with transportation challenges who receive the same amount of support as someone without transportation challenges. However, they require more support or support more often. So what they are receiving is not as sufficient for them as it might be for that person with no transportation challenges. Here's another graph comparing respondents who indicated that they live with an adult who requires constant care. So respondents who indicated that they live with an adult who requires constant care indicated that they do not, we can see that respondents who do live with an adult who requires constant care having needed social supports less frequently than those who do not live with an adult who requires constant care. So again, it could be those who live with an adult requiring constant care have greater needs of social support, and therefore they receive that needed support less frequently. And here we look at a similar graph, but comparing respondents who indicated that they have a history of incarceration with respondents who indicated that they do not have a history of incarceration. We can see that those with a history of incarceration reported getting support for their needs less frequently than those without a history of incarceration. And finally, looking at some health outcomes and social supports. This graph shows that respondents who reported any physical illnesses and/or anxiety or depression, but especially both, on average reported getting support for their needs less frequently. So that concludes the results section of our presentation, and now we'll have some time for questions.
Thank you both so much. We do have some questions in the chat, and I want to get to those. I would also like to just frame the work that has been presented today. So I started as the director of the office. There were no other staff members in late December of 2021. The law was approved by the legislature in January of 2022, and we began hiring at that. I am the we, began hiring at that point. Lara moved over from another department and became our first epidemiologist. We did not have a full staff of educators or outreach people or coordinators. It was me and Caitlin and Lara trying to figure out how government works. So in that process of hiring people, of kind of dissecting the law and charting the course for our office, I knew that we needed data. We were still in COVID. COVID's still here, right? But we were still in the midst of kind of coming back from COVID, and life was still a hot mess. So as good as this survey look, I mean, if anyone tries to say that this does not look good and it is not good work, I disagree wholeheartedly, right? At the same time, we built the survey and began outreach with a very small staff. And so when it came to partnering, when it came to doing community outreach, when it came to translation, all of those things came up early, but there's only so much 3 people can do. And then only so much 5 people can do, because those 2 new people need to be onboarded. And then we need to hire more folks. So a lot was happening when we were building the survey and when we finally began to move the survey out into community for community responses. It was only available in English, although it was up on the website and you can use the Google Translate widget, which we don't recommend anyone doing. That was purposeful because we did not know how to requisition for translation services at that time. We didn't understand the legislative process to move money through a budget. We didn't know that that request for translation services would need to go out to bid. And then also, once that bidding process starts, whoever wins the bid then has to go through a contracting phase. Like, we wouldn't have a survey at all if we waited to figure all of that out and also implement all of those things. So just a little kind of context to the data that you see. Also, we can stop the screen share for now. Also, I think it's important to note that because we were not able to address language and language access early on, we purposely wanted to dive deeper. So at the onset, we knew that we would have focus groups. At the beginning, towards the middle of the process, Mike joined the team and took the lead, and he and Lara kind of took the survey, built the focus group process and procedures and protocol. We worked with our partners at UB. We did work with organizations. So the VA, someone, for example, at the VA did get the survey. Like, was it a sit down where we talked about it and had a formal connection? No. I know that there was a question about community-based organizations. From the connections that I have and that the other staff, our educators and project coordinators have, we made connections with community groups and organizations when the survey became available, and that went out and we requested their assistance to assist with getting survey responses. The focus groups, and again, that data will come out later on this year. Our intention there, once we knew what the process was for getting translators and interpreters, and also consider whatever translation is done in the focus group needs to then be translated back into English for the researchers to be able to do the work to do the data analysis, right? So there's a lot of layers and bits and pieces that we intentionally looked at, considered, reviewed, and this is the result of that hard work. I will say, while I'm going through the questions, the community health assessment process is coming up, which is a now 6-year process that our office will be leading on behalf of Erie County and the Department of Health. And so there will be more opportunity to partner and to get the community health assessment survey out into the hands of community members. So there will be more opportunities to partner with us in that way. So that answers the multi-language question available in the survey form. How far in advance did you solicit assistance from community organizations? As we were moving along, we had participation in the very beginning when it came to developing the questions, as well as on the implementation side. So community was involved from the very beginning. And let me define community as any non-government office. So academia, community-based organizations, block clubs. I know we did stuff with the city of Buffalo and their block club meeting. So we did our best to get the word out and to partner with organizations. Is it possible to see the end for the pie charts? So the report is 324 pages long. That data is actually in the report. I know we had a slide up for the general end for our demographics. Mike, if you want to pull that up so folks can look at that. And you can see, I think, I won't even tell you what I think. I'll just wait for Mike to pull up that slide on what the ends were for all of the demographics. However, I will say the way the survey was prepared and people were able to answer questions, if you were, for example, a vet, or if you were someone with a history of incarceration, we gave people the opportunity to answer "do not wish to say" for every question. We wanted people to be comfortable sharing what they wanted to share and keeping close what they wanted to keep close. A part of allowing space for people to be seen is understanding that they may not want to be seen the way you want them to be seen, right? And so we wanted to make sure that we gave people that space to opt out of any question.
Hey, Kelly. So just to jump in, we did have 173 individuals that said they had a history of military service. So that's your big N overall. The number that then opt out to answer any individual question definitely varies. But as Kelly said, we actually do have then a table within the appendices that shows like the number of do not wish to say or unanswered questions for each individual question, which as a data nerd, I find that table pretty interesting to see the types of questions that people choose to say I don't wish to say or completely skip. So all that's in there. And just as another plug, like if there is a need for specific numbers that we didn't present, if you want the N put on those pie charts or any other breakdown of the data, just reach out to us and we can make that information available to your group or organization. That's why we did this, so that we can share it with the community. So if you have a specific data request, just let us know and we can put that together for you.
Also in the appendices, we do list all of the events that we went to. Again, that's only reflective of the Office of Health Equity. It's not reflective of the work that the Witness Project did in doing door-to-door work. We do have the zip code data for the work that they did. Can you, sorry, what events, meetings, outlets did you use? All of that information is in the appendices. There's a table and it tells you the event and the date that we went to that event. Max, what if the legislature requests our presence? I'm not asking anyone to ask the legislature to ask for our presence, but if they ask, well, I mean, we'll show up. But they all have access and received copies of the report, so they have access to the information. Mike is the best point of contact, but Mike, can you put your email address in the chat? So our data team is available to dive deeper into the data and answer specific questions you may have that aren't, answered in the report. We're very purposeful in the design of the report so that each page really can be taken out and used by community-based organizations, communities, in better understanding health, in getting funding for the work that they do, and being an advocate for themselves. I want our office and our work to always be leveraged by the people to be able to increase the health of Erie County residents. So if you open up the book and see a page, like that page was written for someone to be able to take it and use it as is. So we did a lot of work to not be too technical in the verbiage used so that anyone could pick up the report and use it and understand the work that was included in it. You asking to experience capacity, climate conditions like extreme heat or flooding or snow. We didn't ask specific questions there. However, we do have a report on emergency preparedness that we're in the process of working on. The questions were only asked within the city of Buffalo in partnership with the city of Buffalo during their emergency preparedness events last year. So that work is forthcoming. We will share that out. We will share it with the city first because that was the partnership, and then we'll share it with everyone to be able to have that information. A lot of the questions were perception based. I believe, Broderick, you asked about not reading too much into the data. So again, this was not a representative sample, right? We specifically went to communities where we know there are poorer health outcomes. In addition to that, we gave people the opportunity to not respond to specific questions, but we also asked questions from a qualitative perspective. How do you feel about your finances, right? Like you can pull census data and you can see how much people are making, what their educational attainment is. Like there's data that exists that gives you the specifics within a census tract. We wanted to know how people feel about that. And so someone may not feel they have enough resources, and according to the data, they do. according to the data, the hard data, like census data, you can look at it and see that they're living at or below the poverty line, but they may feel fine about their circumstances, right? So a lot of this was not just the hard data questions. It's about how you feel about your situation, so that we can dig deep. We wanted to be as open-ended as we could, but narrow and specific at the same time, to be able to see where we should be doing the work and where the community would want us to be. There's a question about a spreadsheet of the data as well. Would people be able to access the data? It's tough to extract items from the PDF if we're going to set up comparators. Can you just speak to that around data access, Mike?
Sure thing. It's actually something we're trying to figure out the best method for being able to share a data set publicly. In the interim, until we kind of work through that IT hurdle with internally, if you have a request for some set of the data, if you want to know how veterans responded to surveys, we can pull that data and we could make that data set available to organizations if that's their need. So again, I've our contact information, mine, reach out to me and we can work on getting you data that you're interested in from the survey.
Thank you, Mike. And also in the report, in the appendices, we have all of the questions, the actual survey questions and options. We have the focus group, consent forms, we have the flyers, everything that we did to put this survey together and to deliver it and do the analysis, like all of that information is in the report and in the appendices. We did our best to be as transparent as humanly possible. I've got a staff of 13 people, and we can't do this work on our own, right? Even if we had the staff of the Department of Social Services or all of Erie County government, we still can't do the work on our own. And so I want to make sure that everything we do is made available to you so that you can take it and run with it. We only are, say, authorized, but called to pilot programs and develop best practices for Erie County residents. Once we do that, we need others, including Erie County government, but we need others to take that and then implement it on a wider basis. That's not the work of our office. Our office is to analyze, to connect the factors, make those recommendations so that the work can be done on a larger scale. We don't have the capacity or the calling by the law to be able to do the work on a larger scale. So best practices, lessons learned, all of our forms, everything that we do will be left in the public domain, like this 324-page report, for you to be able to take it and run with it. So a good example would be our holistic health pilot project that we ran on the east side of Buffalo. We received funding from New York State to run that pilot project. It had a very specific focus to highlight healing, alternative healing methods and activities on the east side of Buffalo. That work is available and is in this report so that others can take it and modify it for their community. So we can only do so much, and we're going to do as much as we can with what we have. But the goal is always to use that to develop a framework for others.
Hey, Kelly, I saw a question in there about number of participants. Someone missed that.
Oh, yes.
So we initially collected about just a pinch under 4,000 raw survey responses. After cleaning, removing individuals that realized that they live in Erie, Pennsylvania, and stuff like that, and those bot responses that we unfortunately received, the inclusion was right around 3,400. 3,450-ish responses for the survey in general. And then I did see an additional question related to kind of point in time information. So as Kelly started this presentation, the office is all of 2.5 years old or so here. And so this was our first data point. So definitely on my plans, my long-term plans, we definitely intend to revisit some of these questions to see if we have any changes or any trends with any of the data we've collected. But since most of these questions were uniquely asked and the first time we've asked them as an office, we do not have any timeline trend information to go with the data at this point, but definitely something maybe down the line.
How will this report be used to drive systemic and policy change within Erie County Department of Health as a whole? Government sometimes operates in silos, very much so. We make recommendations and we do the work that we do so that others, including Erie County government, can take it and run with it. Our office can't write a law. We can provide data, right? But that needs to come from a different part of Erie County government. We can't write an executive order, right? That comes from the county executive. So there are functions outside of our office that also need to do the work. There are, laws at the state level that we have no control over whatsoever that the Department of Health's job is to simply implement. And so we can't change those. What we can do is have an equity lens in the work that we do so that when we're interacting with the public, so that when we're developing policies and procedures, it has an equity lens. In this case, it has a health equity lens with a focus on health outcomes. One of the things that I did when it was just me and Caitlin and a box of supplies was to rewrite some of our job descriptions so that I could, one, have jobs available for people that can actually do the work. It does not require a master's degree to do most of the work in our office, right? But that was the job requirement for most of the positions. And so I had that removed. A lot of this work is understanding what you can do in order to make systemic change. I had to realize I am the government. That was a deep moment of realization for me. And I'm not gonna lie, it hurt my feelings, right? I did not want to, I'm being totally transparent in a recorded webinar, right? Like I didn't want to be a part of the system, but in order to make the change, for me, that is where I landed, right? And so in this space, what does the government need to say? So between 8 a.m. and 4 p.m., I am speaking as the government. I have to be careful in my words, but at the same time, what does the government need to say? What work do we need to do? Our office is able to do many things like pilot programs that social services or Department of Mental Health or even the Department of Health can't do because by law they can't, but by law we can. And so finding the space for us as an office, this group of 13 hardcore folks, to be able to make change and document that so that you, be it you, Erie County government, be it you, Erie County legislature, be it you, Erie County community-based organization, you, Erie County Fire Hall, like whoever you are, a healthcare system can take it and run with it. It is at least necessary for me to know that what we're doing can be scaled up and can be built in a way that folk can take it and run with it. So there's examples of policy changes in there. You can take it and change the policies at your organization. You don't have to wait for Erie County to do it. You can be the change. And how can we all in our office be the change? There is a movie that I reference in our office all the time, Drumline. The band director and the team all shout out one band, one sound, right? The drum line can't be off and in the horn section also playing a different song, right? We have to all be in alignment. And so for our office, it's important for us to all be in alignment and show that so that we can all be one band, one sound. If we think the tuba section is the best section, but the the drum line is not, then the sound's going to be off. The health is going to be off. So if we think that only one group of people should be healthy, we're not going to be healthy. One band, one sound, whether it's this office, whether it's Erie County government, whether it's a school district, one band, one sound. We all have to be on the same page in order to move the dial and for Erie County residents to be healthier. Any other questions? We, the community, can help your office. Thank you very much, Stan. And thank you guys all for being here with us.
I did see another question hiding in here,
Oh,
Kelly.
okay.
The focus group report is in progress. It'll be released at some point this year, but no deadline or no date available yet. But this year we will have that report, as well as the winter weather report that Kelly mentioned as well. You can expect both of those reports to come out from the office over the course of 2024.
And we also have on the website, I put that link in the chat. If you go to the health equity page of the Erie County website, at the bottom of the page, you'll see all of our newsletters. The newsletters speak to a lot of systemic issues and systemic changes that can take place. Those were created not for us to deliver to community and outreach, but for you to take and deliver and use in the work that you do. We again, our goal is to provide the framework, to provide the resources, to provide the tools that others need, including Erie County government and others, to be able to make the change and do the work. So you'll see that those newsletters are translated into 6 languages, or available in 6 languages, in English, Spanish, Burmese, Bengali, Arabic, Swahili, because we want to reach people where they are. We don't speak all of those languages here. We speak a couple of them, but not all of them. And we know that just because we don't speak that language doesn't mean that the people don't need the information. So we're working hard to do the work. And I appreciate your feedback. Please feel free to reach out to us. You can reach us at healthequity@erie.gov. That is now in the chat. That email comes directly to me, so feel free to reach out if you have any questions or suggestions. And there's our contact information. Anything else, folks? Thank you. We'll stick around here for a couple minutes, and thank you. Feel free to sign up for our newsletters to stay in the loop. We try not to inundate anyone's inboxes, but we provide grant assistance, we provide data assistance, we provide mental health first aid free of charge to Erie County residents and folks that work in Erie County. We have our Children and Youth with Special Healthcare Needs program, where we provide referral services to children and youth with special healthcare needs with an equity lens, so they don't have to have a diagnosis. There are a lot of services, pilot programs and things like that that we offer in the office, and that information is all available on our website. Thank you, guys. We can end the recording, Laura.